AAN's annual meeting was another success this year. We really had a record attendance. We also had a record submission of the original work, which was both presented in the oral platforms and the poster sessions. As you know, the science at the AAN is very diverse and also very abundant. There are multiple premier science sessions at the AAN, which are called plenary sessions, which begin on Tuesday with a presidential plenary kicking off at 9 a.m. and then goes throughout each day of the week and goes through clinical contemporary issues plenary, hot topics, frontiers in neuroscience, and clinical trials. There's also very specific thematic programming at the AAN called integrated neuroscience sessions. We had 12 of those this year, and they're very popular because in a 4-hour span, they combine in a thematic way the expert presentations, oral presentations by the presenters within a data blitz oral sessions, and the poster sessions as well. I think that this year was actually particularly interesting with regard to the clinical trials results. We've had clinical trial results that came out in 3 different formats. One was a plenary session on clinical trials, which I'd like to also mention to you. But another one is emerging science. A very important trial came out, as well as the invited science in stroke. That's the session. This year in the plenary, among 5 clinical trials presented, there were represented multiple subspecialties, neuromuscular, for example, MS, stroke. Couple of very interesting original trials. One is phase 3 trial that came out of France on high-dose biotin in progressive multiple sclerosis. It was a fairly small number of patients, but all of them were very unique with progressive, not relapsing or remitting multiple sclerosis. And that trial had shown that high-dose biotin prepared in a specific pharmacological compounding way was actually effective in delaying disability in this patient population. I think it was a well-conducted trial, phase 3. So normally phase 3 trials are larger trials, but in this case it may mean that actually smaller amount of patients was needed to show a benefit of that particular supplement, which is as long as the trial design was appropriate, which we think it was. It very well justifies the findings. I think it's very important because currently, patients with progressive multiple sclerosis, as opposed to relapsing remitting, which has multiple options, have very limited options. So adding another supplement or another medication that has a known low toxicity profile may actually add to overall quality of life in patients. I think we not completely understood the kind of a spectrum of multiple sclerosis yet. Relapsing remitting multiple sclerosis is an inflammatory condition, and we think that a whole variety of anti-inflammatory medications, including interferons, have really been successful in curbing the disease process. Progressive multiple sclerosis may be somewhat of a more complicated entity, and so far, anti-inflammatory medications alone were not as successful. There was a specific invited science stroke session at the AAN, which we put together in response to the coming out of a very important number of stroke clinical trials. Perhaps you've heard about it. There was a trial that came out in October of last year called Mr. Clean. This is a Dutch trial which basically put to the test intra-arterial intervention in acute ischemic stroke in addition to using IV TPA. Mr. Clean was really a game changer in every sense of its word. For years we had a kind of an understanding that the treatment that he tested in the trial should work, but we really didn't have any systematic data. So in a single country trial, he's been able to enroll a record number of patients who were randomized either to intravenous treatment with TPA or intravenous treatment plus mechanical thrombectomy, and had actually showed that adjunct treatment with mechanical thrombectomy was effective with regard to the outcomes. Why is it important? Not only we now have greater level of evidence that these interventions work, but also it actually served as a signal to ongoing studies of similar design to stop the proceedings of their trials, review their data, and demonstrate that actually there was already evidence of overwhelming efficacy among the other trials. This way, 4 additional trials to date came out, so we now have 5 phase 3 randomized trials that show that mechanical thrombectomy worked for these patients. What we know is that particular treatment affects a fairly small proportion of patients. Unlike IVTPA, that can be used generalized in many populations for different severity of strokes and under certain selection criteria that prevents bleeding complications. This type of treatment is specific for what we call large vessel occlusion. So these patients who come into the hospital, off the bat, you don't know whether they're going to have a mild stroke or whether they're going to actually have large vessel occlusion. That's why it requires specialized care. It requires specialized diagnostics. So all of these patients have to receive what we call angiography, and most of the time it's a very simple one, adjunct type of vessel imaging that we use in CAT scans. So CAT scan angiography done in this type of patients will be able to diagnose whether these patients do or do not have large vessel occlusion. For those who do, and who still have a fairly large amount of tissue, brain tissue that can be preserved, and also they have certain timing that we're currently talking about 6 hours, maybe 8 hours, as one of the 5 trials had shown. For them, this is certainly good news. One of the trials that I wanted to talk about is early trial. I think it's a phase 1B. It's a trial of a new monoclonal antibody that was tested in patients with prodromal and mild Alzheimer's disease. That was, I think, first of its kind trial that actually pre-scanned the patient, diagnosed them with presence of amyloid plaque on a PET scan prior to initiating the monoclonal antibody treatment. It was initially said to be a safety trial, but also in the course of the trial, they were able to look at some of the efficacy, again, based on PET imaging. It was very interesting to see that in 166 patients that were enrolled in this trial, again relatively small, in 7 different arms, they have been able to differentiate some of the preliminary effects of this monoclonal antibody. I think it's too early, of course, to apply it to treatments, but it actually indicates a couple of interesting lines of research. One is that now that we know that this treatment is relatively safe, I think they'll be able to expand the scale of the investigations and not only look at the burden of the plaque in the brain, but also will start following the clinical outcomes in these patients. And 2, I think it actually bridges a very important divide between the diagnostics and actually future treatments, because in many of the cases, Alzheimer's disease is not diagnosed in time. It's usually diagnosed a little too late when the clinical symptoms become obvious. At that point, we know that the changes that had happened in the brain are way beyond salvageable component. You can't really reverse them. You can only potentially mend the outcomes. In this case, if you catch the patients in what we call a prodromal phase, very early phase of cognitive impairment, these changes could be potentially aborted and maybe even reversed. A phase 2 randomized trial in optic neuritis that had shown that very well known medication that's already been in the market for decades called phenytoin may potentially have neuroprotective effects. Very interesting study has been presented in the clinical trials plenary by an investigator from the United Kingdom, where they demonstrated that in patients who were exposed to phenytoin after onset of optic myelitis, they actually have shown improvement in thickness of the retina per se following the treatment as compared to placebo. So optic neuritis could be part of the syndrome of multiple sclerosis, could be part of another very specific syndrome that's called neuromyelitis optica, or could be an isolated disorder. In fact, in some individuals, disease never develops beyond developing multiple bouts of optic neuritis. So in this case, it actually could provide an option for these individuals with isolated treatment, or could serve as an adjunctive treatment for patients with broader syndromes such as neuromyelitis optica or multiple sclerosis. There's an entire part of the field that actually is working on predicting progression of the disease. And this disease progression, certainly in MS, often starts with optic neuritis and then and then develops into it. There are scales that have been developed, there are clinical rules about it, but in certain proportion of patients it's still very hard to predict. This particular study was focused on a specific treatment because, as you know, disability that can emerge from optic neuritis is really devastating, loss of vision in many cases. And even though this study did not necessarily show improvement in vision, but it did show the preservation of the thickness of the retinal cells in this case. For the future, who knows? This may be, again, as an adjunctive treatment, it may demonstrate qualities beyond protection in just this particular condition. But I think that's that's a matter of future testing. I think almost every finding, I should say, contributes to an overall complexity of the biology of disease in each particular case, whether it's stroke, multiple sclerosis, whether it's some other neuromuscular disorder, for example. And these findings, they kind of feed from the different angles into the disease pathology, which I think helps in the future to build a better story and hopefully find better treatments in the complex disorders that we deal with. What you're looking at is how not just the trial result perceived by the medical professionals, but how it's implemented in real practice. And that was actually one of the reasons why we wanted to bring Mr. Clean trial results to American Academy of Neurology, because with a record attending of over, I think, 13,000 individuals at that meeting, majority of whom are actually non-specialists in stroke. What is that these individuals will take this practice and take it into their communities where this indication is most needed, as opposed to just being a property of very small elite community of specialists, even though knowledge most of the time trickles from a subspecialty into a general public.